So, contemporary approach to just patient care. Jonathan Trent. I would say one thing when I introduce both Jonathan and Mike Convick, who's going to follow him up. You're going to start wandering up here, Mike, in a minute. Okay. These two guys both failed a course in medical school called medical arrogance. And flunked the course, both of them. Okay. And those of you who have made the circuit of dealing with different doctors around the world understand what I'm talking about. When doctors have a combination of compassion as well as medical skill, you got something real special. We've become friends over the years. I've never heard anybody say an unkind word about either one of them. So let me introduce my first friend, Jonathan Trent. Jonathan.
Events like this are really one way for us to advance the field in terms of knowledge, in terms of getting together to discuss future research projects that we can work on together. I'd also like to thank the organizers, the LifeRaft group, Norman Scherzer, Sarah Rothschild, Laura, everybody else for putting together this event. And I'm going to really just lay some of the overview of where we stand with GIST today as we do in our practice. In 15 minutes, I cannot go over anything, so I'm happy to meet with anybody afterwards to discuss anything y'all want to discuss. So GIST in the early 2000s, as Norman was discussing, was GIST. There was one disease, one entity, known as GIST. Now fast forward to 2018, we know that GIST is actually a collection of many different diseases, similar in many ways, but molecularly, genetically, very different diseases. And this is sort of some of the types of GIST that we see today, and I'll get back to this as to why this is important. GIST, we know, has a particular pattern, clinical pattern. We know that GIST spreads to certain areas. When a GIST is resected from the stomach, from the small intestine, from the rectum, esophagus, we know that there is a particular metastatic pattern, including, namely, the liver and the peritoneal cavities. So we have to make sure that we adequately image those areas in terms of radiographic imaging. In our practice, patients with GIST generally get interviewed for new symptoms, get examination. Patients undergo a chest x-ray and a CT abdomen and pelvis. Chest x-ray is often left out. I've seen in many other practices outside of Sylvester, but we think chest x-ray is important because, as you can see on this list, lung metastases do occur. They're rare, but they do occur. And also from research in nearly 800 GIST patients in our database, we found about 17% of GIST patients will get another cancer in their lifetime. So we've been able to detect early lung cancer using this approach in other entities. The pattern of metastasis is also different. This is something that has evolved from GIST in terms of all the solid tumor oncology. So GIST can spread, as I mentioned, to the liver. Common site is the outside of the peritoneal cavity is the liver by far above any other site. But there you can see a couple of distinct patterns on this cartoon. Patients may have a situation where there's only one lesion in the liver. In that situation, we call that oligometastatic disease. That one lesion may be able to be treated certainly with systemic therapy. It's metastatic, but also through localized procedures such as embolization, arterial embolization in the liver, radiofrequency ablation, or even surgical resection. However, when patients have more widespread disease, such as multiple sites in the liver, a surgical approach might not really be feasible, whereas hepatic arterial embolization ablation, radiofrequency ablation, NanoKnife might have a role. Multi-organ disease, widespread throughout the abdomen, an approach using surgery is generally not recommended as the initial therapy. A systemic therapy is recommended. However, in patients who do respond to a targeted tyrosine kinase inhibitor, there may be a role for localized therapy in the future. So we mentioned some of the different molecular subtypes of GIST. The most common above any other genetic event that is the driver mutation in a GI stromal tumor is a gene called KIT. KIT is a receptor tyrosine kinase. It's a protein on the surface of the tumor cell. As you can see in this cartoon, it sends a signal into the nucleus of a tumor cell to tell that cell to grow, to proliferate. In other words, to split from one cell into 2, into 4, 8, 16, 32, 64. Next thing you know, you have an exponentially growing tumor. And this not only drives the mutation, not only drives the proliferation, but the mutation also tells that GIST cell to invade into blood vessels, to spread to other sites in the body, such as the liver, to set up shop and grow there as a metastasis. The signaling also helps GIST grow large in terms of recruiting and creating blood vessels within the tumor through a process called angiogenesis. And as you heard from Norman, a medicine named Imatinib was the first tyrosine kinase inhibitor that we use in GIST, and it potently binds to this tyrosine kinase receptor KIT and turns it off, similar to turning off a light switch. When that signal is turned off, not only does that proliferation stop, but those cells actually die. Programmed cell death called apoptosis. So those cells die. They no longer are proliferating. They no longer can survive. They cannot invade. They cannot metastasize. And it's exceptionally effective in the majority of patients. Not every single patient, but the majority. And so that led to a number of different therapies. The initial therapy to treat patients with metastatic GIST is a medicine termed Imatinib. Other players came into and showed activity such as Imatinib and Regorafenib. And this is just data, a summary of the large trial. This is a large trial in the United States of over 700 patients, 900 patients in Europe. At our site, we put over 100 patients on this study, and the patients were allowed to cross over from 400 to 800. We learned a whole lot from this study in terms of the genetics, but also in terms of how to use this agent. Most importantly, the median survival for a patient with metastatic GIST prior to Imatinib was about 9 months. Now today, more than half of patients live more than 5 years. In this publication, in our practice, we see at more than 7, 8 years. Many patients are surviving more than a decade. We also learned that tumors may not get smaller. This is a spectacular response to therapy. You can see by the yellow arrow. They may not get smaller, but they can certainly change. So this is that turning into liquid that Norman just mentioned. We call it, it's cell death. Cells are dying, blood vessels are going away. It's necrosis, and dead debris is left behind. So this is a spectacular response to therapy. Although the radiologist may call it stable disease, there are certain situations where a tumor might even get a little bit larger in terms of swelling, edema, hemorrhage within the tumor when it's responding. So we've learned a lot on the radiographic imaging of the disease. So not only is it complicated in terms of pathology, and every biopsy sample should be reviewed by a GIST pathologist when possible, but also the imaging should be reviewed by somebody experienced with GIST. We learned a lot on side effects. So these are the common side effects that we see with GIST. These are worse at higher doses of Gleevec. And so most of these side effects we've become pretty good at treating. We've become pretty good at preventing. So if a patient is having, for instance, diarrhea, we use Imodium, Imodal, tincture of opium to get ahead of the curve and prevent those side effects. One of the more difficult, challenging side effects is fatigue. I'm certain many of you have been impacted by this. Fatigue is multifactorial and really takes a workup to rule out anemia. patients, sunitinib is similar to imatinib. It inhibits that KIT molecule and turns it off a little bit different way. But importantly, it also turns off another pathway called VEGF receptor. VEGF receptor are important for forming blood vessels in GISTs. And those blood vessels are supported by VEGF receptor, and inhibition of that pathway theoretically could add additional efficacy to tyrosine kinase inhibition against KIT. So this trial compared sunitinib versus imatinib and showed that sunitinib was better than taking placebo. Sunitinib versus placebo. That was a Freudian slip. Placebo doesn't work very well in GIST patients. Regorafenib, and then another study after failure of sunitinib was looking at regorafenib versus placebo. And again, regorafenib is much superior to not taking anything. So placebos are really a bad idea. We try not to participate in those types of studies, and I commend the pharmaceutical companies who do active controls and stay away from placebos when they can. And so you'll notice in this study that the patients on placebo actually did worse on the prior study. Data in a Korean study showed that continuing imatinib is even better than taking a placebo. So patients who progressed on imatinib were randomized to either continuing imatinib or taking a placebo. Continuing imatinib is better than not doing anything at all. So I've mentioned a couple of types of progression. This is important clinically so that you're aware. Patients, and we've learned a lot from imatinib, sunitinib, regorafenib also in this setting, because patients who have their tumors growing are not all the same. Patients can have a tumor that grows in one lesion. So you can see this on the top cartoon of the liver. You can see a bright spot. That's one tumor, one area of the 5 areas that are growing. The other 4 areas are not growing at all. So one approach for this limited type progression would be to treat the one that is growing and enlarging and continue the kinase inhibitor, imatinib, sunitinib, regorafenib, to continue to treat the ones that are growing. And this has been very effective in our practice. And similarly, when a patient responds to a kinase inhibitor, such as imatinib, sunitinib, regorafenib, you can have nodular progression. That's a little nodule in the rim of a previously treated tumor. And this can also be treated with a localized approach, such as surgical resection, embolization, radiofrequency ablation. Now, when a patient at the bottom has widespread progression and tumor nodules are enlarging throughout, it's time to consider switching a therapy, sunitinib, regorafenib, or looking into a clinical trial, as my colleague Mike Heinrich is going to be discussing in a few minutes. This is an example of embolization. So this patient on the green arrow has an angiogram performed of the liver. There's a liver nodule. It's the only one that's enlarging. That nodule has a distinct blood vessel and artery that is feeding that tumor. That artery can be selectively filled with bone particles that swell up and choke off the blood supply to the tumor. And you can see on the yellow and red arrows, this is the tumor. We call this a tumor blush. You can see all these blood vessels in the tumor are making it darker. And then after embolization, there's no more blood in the tumor. But guess what happens when a tumor has no blood coming to it? It dies. And so this is a highly effective therapy. We looked retrospectively at our data, over 100 patients, and we found that 65% of patients who were chosen to treat with this approach have a response to therapy. There are off-label therapies. What do we do when we run out of imatinib, sunitinib, regorafenib? Number one, look for a clinical trial. And again, Mike Heinrich is going to discuss those. Some patients are not eligible for clinical trials. Clinical trials may not be available. So we also have to think about off-label therapy. Off-label therapy take different flavors. KIT inhibitors for KIT mutant GIST. These have all been looked at in retrospective studies, some in clinical trials, and these are FDA approved and available for other types of cancer. But we know they have some activity in GIST, and our social workers are pretty good at getting these from patients with limited information. Certainly RAF inhibitors are available for RAF mutant GIST. This is just to remind us that there are patterns of metastasis in resistance that involve the KIT gene in different areas. This is a slide that Mike gave me 3 or 4 years ago. He may not even remember giving me this slide, but I modified it a little bit with his consent, including some Imatinib data showing that mutations genetically are different, and the drugs that we use to treat different resistant tumors have different predicted sensitivities based on the in vitro data from Mike and other individuals. For instance, you'll see that mutations in exon 13 may be resistant to Imatinib, but sensitive to Sunitinib. Mutations down here in exon 17 may be resistant to Imatinib, Sunitinib, but sensitive to Regorafenib in terms of the green color. Sensitivity. The problem is these tumors may be resistant have different resistant mutations in different lesions. So you biopsy one lesion, you might not find a resistant mutation, or you might find one, you biopsy another lesion, you might find a different one. So we've got to be smarter like that. So one thing we're doing at Sylvester is we're looking at circulating tumor DNA. This is a blood test where you get an overview of the spectrum of secondary mutations that are occurring throughout the metastatic nodules of a patient. Tumor cells, when they turn over, release DNA. This is normal occurrence. That DNA can now be detected in blood from a simple blood test. And so we looked at our data and found that patients who have resistant GIST, who we are able to do circulating tumor DNA testing on, and we're able to base their future therapy on this information, have 1 year survival of almost 90% and progression-free survival of almost 70% at 1 year. And importantly, the median's not even reached. More than half of patients are alive and progression-free at 1 year. So we're looking into more information on this to determine the efficacy of this approach. So I'll just give you one example. This patient has KIT exon 11 mutation. We did circulating tumor DNA. We found a Y823D secondary mutation, predicted to be sensitive to Imatinib. We treated the Imatinib, and definitely you can see the patient from left to right has had regression of the tumor on this therapy. This lasted almost 2 years. And Mike's going to discuss clinical trials. One point is consider clinical trials that include a KIT inhibitor. And I will make one more statement and recommendation to get mutation testing on your tumors. We still see it today. Patients are not getting it. We have a new drug, NTRK translocate, that targets NTRK translocations. It's exceptionally rare, but if you have this translocation, this is the drug for you. I'd like to thank the entire GIST team at Sylvester, and thank Norman for organizing, and thank you guys for your time to discuss this important overview of GIST. And I will answer questions or postpone them until.
So we're going to have Mike come up, and then